great to be here. Great to see everyone. And I'm excited to talk with you all about integrating biopsychosocial determinants of health to develop and implement culturally sensitive care for women. And I will provide a brief example of my research study called the Harmony Study in African American women. Next slide, please. So one of my favorite quotes is, of all the forms of inequality, injustice in health is the most shocking and inhumane. This quote motivates me to do my research as well as my clinical practice as a psychiatric mental health nurse practitioner, as a social and health psychologist, as well as an associate dean of the PhD program of the School of Nursing at UNC Chapel Hill, and most importantly, as a health equity researcher that focuses on stress, coping, and other biopsychosocial processes. Next slide, please. So not only is inequality, injustice, inhumane, we know that without mental health, there can be no true physical health. So what you will notice is a lot of my research and a lot of what I'm going to talk about today suggests that we need to remember the role that mental health, stress and coping, but other mental health factors such as depression, anxiety, the roles that they play in health inequities and in women's health in particular. Next slide. So bioecological systems theory is very informative to me in my research, and I think very informative to us as we consider the importance of more priority placed on women's health research, because women and all of us here are part of a larger system. And so our health is informed by our environment, our family, our church, our neighborhood, places, other places of worship, but also our friends and family, our relationships, social welfare services, as well as what we see here is the macro system, attitudes and ideologies of the culture. So when we're planning programs of research, it's important for us to consider these social historical factors and what has influenced the current healthcare situations we see in terms of time and conditions and context. Next slide. So this may remind you of a common concept called the social determinants of health, which suggests that we cannot just look at biology and genetics, but look at all the other sociological factors, and I should say psychosocial factors that influence health and well-being. Next slide. So as I mentioned before, I'm a stress and coping researcher and have focused my entire training and career on stress and coping in terms of women's health and well-being. So one of the major social determinants of health is psychological stress. We know that it influences our health behaviors as well as physiological responses to stress that both place the health behaviors and physiological responses place us at higher risk for chronic illness, depending on the ways that we select, the ways we choose to cope with stress, and also sometimes unconsciously the way that stress is chronically and even acutely influencing our health status. Next slide, please. So as you've heard today, there are a number of chronic health conditions that need more exploration in research, and specifically when we consider women of color and health disparities, there are numerous chronic health conditions that can be prevented and quality of life can be improved through a greater focus on the nuances and factors that cause these conditions and the more specific ways we need to develop interventions to address these conditions. So you can see here it ranges from cardiovascular disease to obesity, lupus, diabetes, certain forms of cancer, uterine fibroids, adverse birth outcomes, but also disproportionately high rates of mental illness morbidity and underutilization of mental health services. And several models that I use in my research I think are quite informative for us to better understand how to address these chronic health conditions in women, and particularly women of color. Next slide, please. So a little bit about mental health disparities in our population in general. We are in a mental health crisis, as we know, and that has been made worse because of the global pandemic. Approximately 18% of US adults have a diagnosable mental health disorder, and about 4% have serious mental illness. It's a leading cause of disability in the United States, including years lost of life, and the higher risk of chronic illness among people with mental health conditions. Although rates of depression are lower in African Americans, Hispanics compared to whites. Minority groups are more likely to experience risk factors that cause persistent chronic mental health disorders, and they're less likely to receive mental health care in ways that match their needs in terms of culturally sensitive care. Barriers to adequate mental health services include stigma, health insurance issues, logistic barriers, racism, provider bias or cultural microaggressions that may be known or unknown, language barriers, and then we also know that there's a lack of workforce diversity. If you look at the data on psychologists, psychiatrists, psychiatric nurse practitioners, social workers, the percentage of underrepresented groups is extremely low. There's also challenges with geographic access, as well as what we consider norms towards the way that we deliver mental health care. Next slide. And as we mentioned before, there's inaccessibility of high quality mental health services. According to the Surgeon General, despite the existence of effective treatments, disparities lie in the availability, accessibility, and quality of these services. And so if we can't have health without mental health, this is a critical issue for addressing chronic health conditions in women. We need to also consider the mental health contributors to these chronic conditions. Next slide. So when we think about conducting research, as was mentioned by my colleagues just a few minutes ago, we also need to not only consider the research workforce, but also the workforce in terms of healthcare provision. And this goes for mental health as well as primary care healthcare provision, making sure we have providers that can address the cultural and gender relevant factors that will lead people to be able to successfully make healthy lifestyle choices, engage in the healthcare system, and have higher quality of life. And as you can see here, these statistics show the alarmingly low rates of diversity in the mental health professions specifically. Next slide. One of the frameworks that really helps us to see this clearly, this link between, potential link between mental health and chronic health conditions, is the environmental affordances model, which suggests that because of issues perhaps related to stigma and what's available in the environment in terms of healthy coping and healthy behavioral lifestyle engagement, if those healthy factors are not available, and if stigma is related to addressing psychopathology through pursuing mental health care, and if people have more access to poor health behaviors such as diet, alcohol, tobacco, etc., then the mental health conditions, including what may seem less severe, but is really just as important, chronic stress, those things might appear to be medical or chronic physical health conditions. They show up as chronic physical health conditions such as diabetes and cardiovascular disease, whereas what really may need to be addressed is the underlying chronic stress and other psychopathology that may lead to these conditions. So both things need to be considered if we really want to make our population healthier. Next slide. So I wanted to point or direct you to a really comprehensive report commissioned by the American Psychological Association just a few years ago. It's the Stress and Health Disparities Report, and it's a really excellent reference for understanding the role of stress and other mental health factors in chronic illness, morbidity and mortality, and it specifically focuses on underrepresented groups who experience disproportionately high rates of chronic illness. So this is a reference I wanted to share with you today. Next slide. And so I'm going to move more closely to the research that I do as an exemplar for how we might focus on developing culturally relevant strategies for addressing chronic conditions in women, and specifically African-American women and other underrepresented groups. So we know that there's an intersection between race, gender, and socioeconomic status. And those things have an impact on how people experience and cope with stress, leading to stress-related disparities in chronic illness. And in my work, I specifically focus on mental health and stress-related factors that contribute to overweight, obesity, and chronic cardiometabolic risk factors. Next slide. So for example, we know that 80% of African-American women are overweight, 50% at least are obese, and 25% greater than the age of 55 have diabetes. And our research to date has not adequately addressed or developed ameliorative interventions that are sustainable, that have good uptake. And we've had success, but we're still faced with what we call these wicked problems of these disproportionately high rates of cardiometabolic and other chronic health conditions. Next slide. So when we say that stress is a factor, we know that stress can influence chronic illness through all of these various health systems. And people on the outside can be tolerating stress, doing their best to have resilience against stress. Meanwhile, the body is on overdrive working to cope with these stressors that affect our multi-systems that interact in our bodies. Next slide. Stress has an effect on the physiology. Most of us are familiar with the HPA axis processes, the sympathetic nervous system. So there's not one type of area that can be pinpointed to be isolated in the stress response, stress reactivity response. Therefore, it's so important for us to focus on the role of stress in chronic illness. Next slide. And I'll just direct your attention to this lower part of the slide here. These things may be elementary to many of us, but when we talk about them more, we realize how important it is, and it's not a basic thing to explore. So short-term stress response influences our cardiovascular rate, our heart rate, blood pressure, glucose metabolism, our ability to breathe properly, dilation of bronchioles, changes in blood flow patterns leading to increased alertness and decreased digestion and kidney activity and increased metabolic rate. That's the short-term response, but the long-term response, this is just a few examples, include retention of sodium, increased blood volume and blood pressure, proteins, fats converted to glucose or broken down or energy, increased blood sugar, et cetera, and a suppression of immune system functioning. Next slide. And again, this is just another example, and I'll just give you a few moments to look at it yourself. But just again, a lot of different chronic long-term effects as well as short-term effects of stress on health, which cannot be overstated, especially in our current situation, our current social and contextual situation of increased stress and not only individual stress, but what we call network stress. So we're not only experiencing our own personal stress, we're also experiencing the stress of the loved ones, family members, and friends. And so we're at higher risk, higher levels of vulnerability of stress-related chronic illness. Next slide. But what's critical, because it's not new to include a measure of stress, right, in our research, in order to effectively study and understand the influence of stress on health in women, we must use culturally and gender relevant definitions and operationalizations of stress. So a generic definition or measure of stress may not allow us to understand the nuances of stress in women of color specifically. And so therefore we are not able to develop more nuanced targeted interventions that are going to really make a difference. Next slide. So in my early work under the supervision of Marcy Lobel, when I was way back when I was a PhD student, we did work to identify and just make the point with database, evidence-based research showing that race and gender matter. It's really important for us to integrate that and not only consider how to have the most efficient measures in our research. Sometimes we don't want to burden participants, and so we find like the quick and easy measure, but it's also important for us to have comprehensive and nuanced targeted measurement. Next slide. And so I'm also intrigued, and I think it's really important for us to consider this concept of schemas. So how do we have these mental structures and processes and perceiving and understanding our world around us? And how does that influence not only our relationships, but our motivations, how we function at work and at home, and how that influences the way we respond to and cope with stress? Next slide. So through many years of research, I developed a conceptual framework called Superwoman Schema, a social, cultural, and historical phenomenon with 5 characteristics, including a perceived obligation to present an image of strength, emotional suppression, resistance of support or vulnerability, motivation to succeed despite limited resources, and disproportionate caregiving or prioritization of caring for others over self-care. Now, this is a double-edged sword where women in our research report this as an asset and a liability. An asset in terms of contributing to survival of self and community because of their role as women in their families and their communities, but also a liability or limitation because of how it influences neglected self-care or, as was mentioned before, delayed preventative behaviors that can help us prevent or have less morbid chronic illnesses. And so this conceptual framework, we're finding that it may exacerbate stress and stress-related disparities. Next slide. And I mentioned this already, but it's related to this concept of network stress, which is often not examined in research on stress and chronic illness. But we're finding in our studies that it is just as important as an individual stress. So vicariously experienced stress is just as important to examine so that we can develop appropriate targeted interventions. Next slide. So again, I think it's really important to think about stress, the long-term research on stress, and this is early work, alarm resistance, exhaustion. So oftentimes people are in this resistance stage and they're not seeing how stress is physiologically the physiological mechanisms that are occurring because of this concept that's often used in adolescents and children. I'm not sure if you're aware of it, but it's called skin deep resilience, where people are responding to stress, acute and chronic stressors, appearing to be coping, yet their bodies are having an experience that may only show up when we've gotten to the point of exhaustion, when we have symptoms or even diagnosis of these chronic conditions. Next slide. So I'm going to start to conclude by showing you framework. There are no directions here because we're exploring this, but the role of Superwoman schema characters influencing stress and distress, how it influenced in these physiological stress mechanisms, as well as behavioral responses to stress, such as coping, eating as a coping strategy, sedentary behavior, which then influences body composition, such as BMI, leading to psychoneuroendocrine as well as immune-related outcomes. Next slide. So we're not only addressing Superwoman schema by focusing on its characteristics, but also looking at the fact that this did not just occur in a vacuum. There are antecedents that in terms of culture, society, et cetera, that may have caused these attributes as well, and these characteristics, as well as manifestations and resulting health outcomes. Next slide. And I'm going to go through these quickly, but we've developed a psychometrically robust scale to examine these research questions we have. Next slide. There are items that go along with each of the 5 characteristics of Superwoman schema. And again, we found this to be psychometrically rigorous and strong. Next slide. We found initial associations with higher depressive symptoms, higher perceived stress, lower sleep quality, higher use of food to cope, emotional eating and binge eating, and lower physical activity. Next slide. We've worked with numerous investigators, and these are just a few here listed that have looked at things such as lupus, cardiometabolic risk, allostatic load, telomere activity, and all of these studies are building the evidence on the importance of stress and Superwoman schema in particular to understand health disparities in African-American women. Next slide. And what we're finding is that some of the aspects of Superwoman schema, like strength, are protective, but emotional suppression and specifically the caregiving, prioritization of caregiving are consistently associated with outcomes such as allostatic load, shorter telomere length, and other outcomes that are related to adverse chronic illness. Next slide. So through a series of research funding, mostly from NIH, but also from foundations such as Macy Foundation, Robert Wood Johnson Foundation, and SAMHSA, another federally funded project from SAMHSA, we have got into this intervention called the Harmony Study. Next slide. And with harmony, we are using all that I just talked about, a knowledge about race and gender matter, social factors matter. What I didn't mention so much, social relationships matter in terms of how women respond to stress and how stress might then lead to cardiometabolic and other chronic health conditions. So the Harmony study is using all of that evidence to try to reduce cardiometabolic risk that results from psychological stress in women. Next slide. And this is just an example of some of the things we're using to measure the outcomes of harmony, both subjective and objective measures, to understand behavioral lifestyle change and psychological stress change, as well as self-care changes to promote chronic illness prevention. Next slide. And so in summary, I will just say that disproportionately high rates of chronic conditions in women continue to be shocking and inhumane. We need to include contextual and biopsychosocial processes in our research to understand and address these conditions in women so that we can have better outcomes and interventions that will increase wellness and quality of life. And as my colleague said before, the Office of Research on Women's Health should become an institute so that we can have greater capacity for the research advancements needed to address biopsychosocial processes in women and health inequities in underrepresented groups. Thank you so much.